ப்ளே பண்ணுங்க. ஸ்பான்சர் வீடியோ. எந்த ஸ்பான்சரு? அப்படியா? சரி போடுங்க. அதுக்கு எனக்கு டைம் கொடுக்கணும்.
என் கண்ணே பட்டுடும் போல இருக்கு. ஆண்டி இது என் அப்பா. சாரி, என் ஐசைட் அப்படி இருக்கு. நான் போயிட்டு வரேன்.
எல்லா ஆல்பமும் ஒரே மாதிரி தானே இருக்கு.
ஃபாரின் படம் பார்க்கலாமா?
Why not? என்னால சப்டைட்டில்ஸ் அப்படியே படிக்க முடியுது.
Oh, like that.
எதை பார்க்கணும் எதை பார்க்க கூடாதுங்கிறது உங்க சாய்ஸ். டாக்டர் அகர்வால்ஸ் வழங்குகிறது வலி இல்லாத தையல் இல்லாத சர்ஜரி மற்றும் அதே நாள் டிஸ்சார்ஜ். டாக்டர் அகர்வால்ஸ் ஐ ஹாஸ்பிட்டலுக்கு வாங்க, வித்தியாசத்தை நீங்களே பாருங்க.
So did you get any printout? Not yet? Okay, there are 4 things which are important in each of these presentations. Originality of the new idea or the innovation, the scientific value for it, it's more like how you can value that kind of a device, and then whether you will apply it in your practice or somebody else can take it to the application value. And finally, the quality of presentation, which also includes the time limit which they are getting. I think they're getting 4 minutes, and then we'll have a 2-minute of quick question and answer to each of the presenter. So I think you're getting a copy of that. By the time we'll start the first presenter, we'll have a very interesting line of ideas which are going to be shared. The first is going to be Dr. Fatima. She's going to talk how they have developed an idea for your customer or your patient to feel a progressive lens. How do you give them a feel even before you dispense the glasses? So they have come up with an idea to do that. So it's like a video, right? It's with a video with an audio. No, you can play that. நீங்க அங்க கூட உட்காரலாம். So you can come when they ask questions. Yeah. ஃப்ரண்ட்லேயே உட்காருங்க. சாத்தியமா சோஃபாலாம் போட்டுருவோம். Why don't some of you come to the front? Come. If you see people moving, everyone should start moving. அப்படியா? இதுவும் நல்லா இருக்கு. நல்லா ப்ளே திருப்பியும் ஆடை போட்டுறாருப்பா.
Presbyopia is an age-related condition typically affecting people over the age of 40. Progressive lenses are hence a strong choice for people who are unhappy with bifocal or trifocal lenses. Progressive lenses offer a much smoother transition when viewing objects at different distances. Corridor of increasing power connects the distance and the near zones, and they provide the intermediate range of vision. Most progressive lenses fall into one of the 2 categories. The standard pals are ideal for larger frames, whereas the short progressive added lenses are designed for the smaller frames. Progressive lenses are thinner and lighter, and they require a higher degree of expertise and technology, which make them more expensive. We, as ophthalmologists, often come across patients who have discomfort with their first pair of progressive glasses. This is often due to the first-time exposure to different powers incorporated in the same lens. The near vision corridor, being in the lower aspect of the glasses, is often affected by the different frame heights. To make these patients happy, we decided to provide the feel of the PAL lenses to the patients before they buy it. The existing progressive demonstration tool developed by SLR is available in one large frame. It is not a universal tool and cannot be used for the regular and the short PALs. Developing a PAL demonstration lens similar to the sunglass trial lenses would be possible, but interpupillary distance is very crucial in the fitting of progressive lenses, which cannot be taken care of in this model. Hence, we address the problem statement of patients having trouble in getting adapted to progressive lenses by developing separate monoocular clip-on trial lenses for both eyes, which we have named as the PAL field lenses. Our plan was to develop monoocular progressive lenses which can be mounted on the patient's spectacles to get an add-on effect and help them understand how to use the lenses and how to see through them. Similar clip-ons can be made in different types of PALs and frame heights to help patients to choose the one that suits them. These could be incorporated into the routine subjective refraction practice in our clinics. For making the simple prototype, we needed patient spectacles, a pair of regular or short PALs, the metallic clip-ons and some stoppers. Now let's see how we made the prototype. Patients can't measure the quality of clinical care, but they can measure the quality of experience. Ours was a humble attempt to improve the quality of their experience through a simple and economical way.
Fatima, you can come here. You have a mic, okay, that's fine. Any quick questions to Dr. Fatima? அவங்க மைக் இருக்கா உங்களுக்கு ஜட்ஜஸ் மைக் இருக்காப்பா?
Well presented. Sorry for my throat. So practically, after doing this, did you check any patients and was there any difference between the SLRs and this one and what you have done? Yeah, use this please.
Hello, good morning sir. Yes, we are using it past 2 weeks. Almost over 15 to 20 patients we have tried. They feel better. They feel easy to select which type of PAL for them to use. The idea started from actually one of my close friend tried with this SLR tool and very happy and ordered an expensive PAL and finally ended up with a high unsatisfaction because of that near vision area which he was not comfortable with. So that is the basic idea, origin of this tool to develop. So we are using it, recently started using it and patients are quite comfortable and they are happy to try that.
Explain that corridor, doctor.
Sir, that regular and short, there is a difference. For regular, it only suits for that larger frame. But optical opticians, they don't explain that much to the patients, and whichever frame patients ask for, they fit in. But that should be correctly fitted. That corridor should be fitted based upon the customized patient's day-to-day need. Like how much they need for near vision, how much they need for intermediate vision. So that kind of so there is a large spectrum of progressive glasses, but every company has a regular and short model. So at least the patient will be able to select which regular model or short model he can choose and then go for whichever expensive glasses patient can afford of.
Yeah. Can I ask a doubt?
Yeah, quick question. Yeah.
The corridor.
Audience or a question.
No, that means like for different people will have different refraction. So you will need to have a full collection of.
No, sir. Yes, sir. Very good question.
Yeah.
Actually, this mainly for a new presbyopes who starts with. So usually they will have 1.25 diopter of near vision.
Okay.
So this is add-on. Whatever glasses they use, they are just adding over it. That progressive has only plano and increase gradient to 1.25.
1 point. So only for those set of patients you can.
That is what we have developed. If if doctor wishes to have a large spectrum, they can have.
No,
For other power
there's
also.
another question
Thank
in the
you.
back. Yeah, that will be the last question for Fatima.
Very nice concept, madam. Most often they have problems walking or climbing the stairs. Like, do you ask them to test with that or only reading?
Yes, sir. The latest modified clip is nicely fitting into the patient's frames. So we can do that also.
No, the testing actually has to involve that rather than reading in front of a thing. That should not be the end point because
Exactly.
walking or climbing steps or climbing down, that's where they have the problem.
Yes.
So, and also like moving sideways, like looking sideways, that's where like new presbyope has a problem. That's probably what you would have to incorporate in your testing.
Yes, sir.
Thank you.
Also, we can extend to bifocal, normal bifocal also, so that patient can select between bifocal and progressive.
Fatima, that's an excellent point. You should, when you give that feel, you ask them to go out, walk in the steps, go up, down the stairs. Because I still remember in China where they send the kids with the myopic glasses outside to even read at distance, which we normally don't do. We kept doing inside the refraction, but when they go out and they start seeing, they feel the real reflex. Thank you again.
Thank you, sir.
We'll have the next presenter, Dr. Prabhu, who will talk about his innovation called Lumi Zoom. How do we do a good subtenon block?
Yes, so very good morning, everyone. Respected judges, seniors, and colleagues. I am Dr. Prabhu, and I am here to present our innovation title, Lumi Zoom. So, subtenon's anesthesia, it's a very safe method of ocular anesthesia, and it provides excellent anesthesia and akinesia for around 30 minutes to 45 minutes. And it's a method that's gaining popularity, particularly for small incision cataract surgery. So, this is a short video demonstrating subtenons. We give a nick through the conjunctiva and the tenon's capsule. And the anesthetic fluid is then injected into the subtenon space. So this is a procedure that is very repetitive in high volume centers, and it takes place in a small working field, and it requires precise skills. So we need a good ergonomic setup to do this, and we need to have good visualization of the ocular field, and we need to have a good illumination. And it's important to give a good block because a good block provides base for a good surgery, a safe surgery. So we currently use a device in our block room for illumination, which is basically a head torch type of device. It provides adequate illumination, but it does not provide any magnification, and does not have an ergonomic design. It's quite heavy and cumbersome to use. And the complications of an improper block include congestion, chemosis, and subconjunctival hemorrhage. These can really obscure and hamper the surgery. And for the block room doctor himself, they either get headaches, neck pains, or body pains on doing this day in, day out. So we decided to come up with a device which has a good ergonomic design in form of a spectacles and provides a decent level of magnification and ample illumination. We give this not as 3 devices, but as a single device titled Lumi Zoom. This is a 3D rendering of the same. As you can see, it can be worn even with people who have spectacles, and it has an LED diode in the front which can be tilted as per the user's convenience. So the magnification is provided by a pair of 1.5 diopter lenses, and it provides good magnification at a working field of 40 to 50 centimeters. And it's powered by a LED lithium battery, and it has a wireless magnetic charging capability. And it has a high luminance mode and a low luminance mode. We mostly use the low luminance mode that provides a battery life of around 10 hours, enough to last the entire day. So we conducted a short survey with eight ophthalmologists in our center, all of whom reported adequate magnification and adequate illumination. But 3 out of 8 reported that the fit was a bit loose. So we rectified that by adding a headband towards the at the end of the device. This ensured that the fit was proper and good and appropriate. And all 8 said they would recommend it to a colleague. So the other applications of our device include that it can be used as a low vision aid. It can be used in microelectrical work. Also, it has applications in dentistry and also general surgery in low resource settings. I'd like to thank my teammates who were involved in developing this device. Thank you. Sir, we have developed the prototype. It is currently in our center. We will work on bringing it out to the market.
Actually, you forgot one very, very important use of this device. You can do indirect ophthalmoscopy with this.
Okay, sir.
I have been actually trying to develop this for the last 10-15 years. This is the cheapest indirect ophthalmoscopy you can have. Fold it and put it in your pocket. Put a 20 diopter lens, you can see the fundus.
Okay, thank you, sir. Thank you for that point.
That's excellent. One more use. It's really a nice presentation, Kaushik. It's really good. So how long are you using this?
We've tested it out with our residents who are in the block room, sir. Some of them are quite comfortably using it. Yeah.
Oh, even if they have a myope, you can adjust
they
it?
They can place it on top. And
they
don't have to wear it all the time, sir.
Okay.
Once they finish giving a block, they just lift it above.
Because I feel the illumination is a key point in subtenance block.
Yes,
that's where the challenge is always. And it's a good, very good.
Yes, so we can correctly avoid the vessels and give it in an avascular area.
So how long does the batteries last? You have to change it?
No, sir. It's a rechargeable battery. It lasts 10 hours in a single charge. So far, we have not had to replace the batteries in the device. Thank you, sir.
Thank you. Thank you, Prabhu. We'll have the next presentation by Dr. Praveena. Dr. Praveena? Yeah. So she'll be sharing pupillary reflex at ease. Play.
Pupillary light reflex is an autonomic reflex that constricts the pupil in response to light. Pupillary reflexes are used to assess optic nerve function and hence prove to be a major breakthrough in diagnosis of many neuro-ophthalmological conditions. Pupillary reflexes are mainly of 2 types. In direct reflex, the response is observed in the eye that is illuminated. Whereas in indirect reflex, also known as the consensual reflex, eyes should be dissociated and the response is observed in the contralateral eye. This warrants the need for an additional source of light to facilitate visualization of the response and a separator to dissociate the eyes. Swinging flashlight test is used to assess the function of one optic nerve relative to the other. This requires switching lights between the eyes through a time period of 3 seconds. As ophthalmologists, we often come across situations of diagnostic dilemma where none of our examination findings would bear fruit except the pupillary reflex response. But these findings often get easily missed at the level of clinicians and optometrists, especially in a busy OPD. Thus, we decided to come up with an innovation that would ease the assessment of pupillary reflexes, which we have named as the pupillary reflex at ease. Our plan was to magnify the irisine pupil using biconvex lenses to ease the visualization of the response and setting up an inbuilt electrical circuit for illuminating the eyes. For eliciting consensual reflex, we decided to dissociate the eyes and provide 2 sets of lightings. On each side, one light is provided to induce pupillary reflex and another low voltage light is set to provide ambient background illumination in equal intensity and in a manner that these will not elicit pupillary response. After some brainstormings, we came up with a primary prototype model made from PVC pipes. Neutral density filters can be used for grading the pupillary response by regulating the amount of light entering the eye. Considering the large size of the device, we felt that the comfort of the patient could be a major concern, and hence we decided to make a compact, snugly fitting device which can be worn like a snorkeling goggles. This led to the development of the advanced prototype model. Now let's see how we made it. 3D printing of the prototype is being done. The electrical circuit is fit with necessary batteries and resistors, and in future, a circuit can be programmed to follow the appropriate timing to elicit related afferent pupillary defect so that this can be easily handled by a single examiner in a comfortable way. Diagnosis is not the end, it is the beginning of practice. Ours was a humble attempt to ease the diagnosis of many difficult to diagnose neuro-ophthalmological diseases, which could prove to be useful not just for the ophthalmologist but also general physicians and ophthalmic assistants at camps and primary vision centers.
Another brilliant idea. I mean, they are coming up with solutions which they face on a daily basis, problems which they face. Yeah.
It's really good. How long are they using it?
Since last 2 months, we have been sending to our neuro-ophthalmology clinics and some camps, and we are like, it's easy to train PGs also on pupillary reflexes, how it is elicited, what are the reflexes that responses that you can expect, and abnormal findings can be elicited, and we can make modifications like an inbuilt system to elicit an RAPD so that the person can be hands-free also.
Okay, thanks.
In these 2 months, you have picked up any RAPD with this equipment?
Not much, sir. We are working on that inbuilt system now.
Nice, very good innovation. Thank you.
Thank you, Doctor. Next, we are going to see something very personal problem and how he has found a solution for his personal problem. But I'm sure it may help a lot of people. Now, this is really, again, thinking out of the box. And we have Dr. Vigneshwar, who is going to talk about why he has created a tall lamp.
Ophthalmology is one field which has seen tremendous developments. There is substantial advancement in various aspects like newer surgical procedures, new medications with lesser side effects, latest diagnostic modalities until the development of artificial intelligence. But not much has been focused on the health or the physical well-being of the doctors or ophthalmologists. The reported prevalence of musculoskeletal disorders in ophthalmologists in various countries ranges between 50 to 80%. This huge number is because our work involves fine motor control, which increases the musculoskeletal tension in the head, neck and the upper extremities. For years, we may not have any symptoms, but when they appear, the damage is already done. There are numerous evidence in literature discussing about these issues and creating awareness, but most of the attempts are neglected because as clinicians in a busy OPD day, the last thing we think about is our posture. Though we can adjust the chair height of the doctor and the patient, the position of the eyepiece of the slit lamp demands the doctor to bend forward to examine the patient. Also, there are certain procedures which has to be done within an arm's distance. Therefore, ocular extenders may not be feasible for common procedures like foreign body removal, gonioscopy, etc. While consciously bending forward at the hip level is recommended, most of the time the movement happens in the neck region and the upper body involving bending, twisting and slouching. On a long run, it leads to disc compression, spinal stenosis and premature spinal degeneration. In order to avoid this, the spine should be straight and shoulders relaxed. Get up and walk around taking micro breaks, consciously adjusting to a safe posture and performing stretches. Though this is simple, with day-to-day practice, we often tend to forget it. The hazards of long hours of sitting is innumerable because sitting is the new smoking.
Recently, in the IT industry, there is a shift towards a standing desk, realizing the hazard due to prolonged sitting. Keeping this in mind, we made a slit lamp model to examine the patient in standing position. We designed a platform for the patient and the slit lamp with doctor standing on the ground as shown in this video. In this method, the environment for the patient and the slit lamp remains undisturbed, being more ergonomic for the doctor. This slit lamp will be useful to examine majority of the patient with ease, whereas fewer patients like wheelchair bound can be seen in the normal doctor's station. The consultation table is not shifted, so after examining the patient, the doctor can sit and type in the computer without the need to twist his body. This model, besides being ergonomic, also converts the sedentary sitting lifestyle to a lifestyle of moderate level of physical activity. It is 5 into 5 feet, which can be made smaller also according to the available room size. Height of the platform is 50 cm from the ground level, which is calculated based on the average height of Indian men and women. There is a bay in front of the platform where the doctor can go closer to the slit lamp without the need for bending forward. There is an elevated ridge which acts as a stopper, preventing the forward movement of the slit lamp. Handrails are provided for patient safety. It is also designed to facilitate eye contact with the patient. Podium can be used whenever needed. Approximate cost is 20,000 rupees. Advantages: it is safe, ergonomic, increases the physical and the mental well-being, universal, cost-effective. We have not come across any major limitations so far. Take-home message: simple changes in routine practice makes a huge difference. By doing this, we are converting a sedentary lifestyle to a lifestyle of moderate level of physical activity. This is a simple yet effective solution which is both a cure and a prophylaxis to prevent musculoskeletal disorders due to prolonged sitting or improper posture.
Very nice presentation. So standing, can you do all the maneuvers what you want to do sitting in a slit lamp?
Yes, sir, it's more comfortable. I have tried toric marking, gonio, all the other procedures that we do in slit lamp, sir. It's more comfortable.
Comfortable.
Yes, sir.
Thank you.
The best thing is you don't have foot pedal, right? Like a phaco where you have to sit and use a foot pedal for your microscope. Here you don't use any foot pedal for a slit lamp. So in fact, interestingly, I also tried for some time and found that no, it really changes the way you practice also.
Yeah, almost 25% of our work time in OP is in front of slit lamp, and this will go a long way.
Can I make a comment, sir?
Yeah.
One limitation is you need a bit more space in the OPD.
Exactly.
And also it's not conducive with your chair unit, where you can do an indirect ophthalmoscopy with the same unit, but here that's probably another setup you need for, that's a limitation.
Exactly. So if you have a busy clinic, you can have 2 rooms like this, where you have a regular chair unit or where you have a regular slit lamp with a tall lamp like this, and whenever you feel your back is paining, you can always use the other room or take the disabled patient to the next room. Either of that will work. These really work for even regular clinics.
Yeah, most of us go through this problem, but we don't consider the OPD thing. Only for the surgical thing, everyone has got this, and we try to innovate in our own way. But it's a very good presentation. Thank you.
Okay. So we have now Dr. EUREKA. She is going to share again one of her problems and how she has found a solution of having a scrub book, a surgical log book.
So good morning, everybody. I'll be talking about scrub book, a surgical digi logbook for every resident. So let us all go back to our first day in a OT, in a cataract OT, the thrill, the anxiety that we all felt, the nervousness. The comments that we got from our trainer that time. So obviously we cannot forget it. And the most important question here is, how did we perfect those surgical steps and tackle the complications? So the initial prototype was What I used was the Numbers app, or you can use the Excel sheet, which most of us used on the. I use it on my iPad, and I used to store the demographic data, the surgical data, the complications, intra-op, post-op, the assisted steps, the assisted by the doctor, and all the post-op complications and what happened into the case. And slowly I realized that just by reviewing at a whole and storing this data, it helped me reduce my complications because I could review it sooner and understand what I'm doing wrong, what are the steps that I need to work on. And also my mentor, my trainer that time, he emphasized on the use of Oscar grading, wherein he used to mark me for each step of the SICS. It is a score of 5 which is given for every step with a total of 90 score. So I realized this was actually a tedious job to record all this surgical data. A trainer cannot monitor it directly, and it was difficult to review it at a whole. That's when hackathon we came up with the idea of Scrub Book. So it's as you can see, it's actually a web-based app right now. So a trainee can make an ID and then we can add patient data. This can be used by any phone or gadget they have. They can add patient data, the demographics, the date of surgery, place of surgery, then any diagnosis can be added like IMC, PXF, brown cataract, soft cataract, any posterior segment diagnosis, and any systemic diagnosis of the patient, eye or surgery, pre-op, post-op astigmatism, pre-op astigmatism, any complications intra-op. You can even add the link to the surgery if you have recorded that surgery, a Google link, and also the assisted step and add the ID of the trainer, because there's a separate login for the trainer. And using this, the trainee can log in data. He can view all the surgeries at a glance at once, and he can see the Oscar grading if the trainer has marked it. So the next video will show how the trainer will mark the trainee for his surgery. So the trainer has to have a login ID, and he can give each Oscar grading for the trainee by if he's seen the trainee do it in the OT, or maybe see the video through the Google link. And it's a simple app, a very simple app that we made in the hackathon. And by this he can review all his trainees' marks and how they are doing. So this was actually a handy go-to app for every resident or trainee, which can be used as a digital surgical logbook. And he can easily store patient data, he can search it anytime he wants at any place. All complications can be reviewed at once. He can be moderated by the trainer, and that further wet lab training can be instructed by the trainer. A surgical link can be given. Oscar grading can be done. And future prospects for this app was to introduce statistics for all complication, alert notification on exceeding complication limit or recurring complications, and surgical lessons by experts, taking it beyond cataract and other specialties, and to hire expert surgeon advice to grade trainee cataract surgeries. So I would like to conclude by saying this is a web-based app for residents, fellows. It can be easy to review complications. It will help to improve surgical performance. Can be used for your CV and also pocket-friendly, used anytime. Thank you.
Good, very good. But training takes time, and then we have to implement, and it's nice you have a logbook, web-based, and then based on that. It's a really good presentation.
Thank you, sir. So mainly right now most of us will use a book, which I feel for the current generation something more digital is needed, is the most important thing.
So it's nice that you have also included your trainer, and then they can also review that. And then periodically, is there any percentage given or evaluation on
no,
that?
No, not yet. So it's very simple app right now, but yes, future. Maybe.
Good. Thank you. Thank you.
Do you have Dr. Pari Kumar here? Yes, sir. Please come. So we'll have the next presentation on, it's a kind of blood vessel sampling during an endothelial test.
Good afternoon, everyone. We're going to talk about blood vessel sampling. It is a portion of blood vessel taken out of the body for diagnostic purposes, not blood sampling. I'd like to begin with a question. Do you know the health status of all your organs in the body? Yes, of course, you will know about your heart, your liver and kidneys, because we have tests for that. but I'm sure you do not know the health status of one of your very vital organ in the body called the vascular endothelium. It is an endocrine organ by itself with multiple functions. And endocrine cell health is a major thing which we all fail to understand, to note. That is the reason why we all live with constant fear of MI or stroke. The research feedback has always been non-availability of human endothelial tissue for diagnostic purposes. And we ophthalmologists are privileged to assess, obtain, observe the blood vessels, and obtain a blood vessel sample from the body. And with the slit lamp examination, we can do a lot of things. Both the endothelial cell lines in the body, corneal endothelium and the vascular endothelium, are in our hands, which gives light and life. We have 4 vascular webs before us. The retinal vascular web is the one which we constantly focus, we talk about. We have a lot of study about this. But before that, we have 3 vascular webs, the palpebral and bulbar conjunctival vascular webs, which we do not focus at all. So we all know diabetic retinopathy precedes nephropathy, and diabetic conjunctival vasculopathy precedes retinopathy is the new observation, and we have a time interval to intervene. We have conducted 2 clinical trials and came up with a lot of interesting findings. The neutrophil infiltration through the endothelial cell lines we have observed, and we have observed also endothelial cell microabscesses. So the pathology could begin at the conjunctival vasculature in a microvascular atmosphere. It could be the earliest sign of any disease progression. We have developed a standard operating procedure, and the whole thing is covered under copyright, trademark, and patent. It's patented in India, in UK, and in Australia. It is published by the British Medical Journal of Innovations. The scope is enormous for research and other purposes. The next in the pipeline is going to be a slit lamp examination for cancer detection. Circulating tumor cell could be observed by just mere slit lamp examination. That's going to be our next study. So the blood vessel sampling may help us in prevent, predict, and prognosticate myocardial infarction and stroke. But the live watch of conjunctival vessels with the cells in it, and we can diagnose cancers and other blood dyscrasias. Earlier days, conjunctiva used to be a kind of place where we look for jaundice and anemia. Now, even today, conjunctiva remains the source of health information. We can diagnose cancer, stroke, and myocardial infarction. It's going to be ophthalmic-dependent diagnostics or ophthalmic diagnostics, which you all are going to be part of this in the near future. Thank you.
Really a great presentation. It's a new thing for me. Venkatesh, what is your opinion on this?
I'm not surprised now because the Google team recently is asking for conjunctival images. Okay, so now they can predict from conjunctiva your HbA1c, your blood pressure, your cardiovascular risk, and I'm sure tomorrow they can say you have prostate cancer or I don't know. Now from your just so now we are collecting Oppo images, not even a higher end camera. They have given some standard specification for mobile phones, and we are collecting conjunctival images. And I'm sure all these evidences also take you towards that, saying that maybe at somewhere you can detect some of these conditions through just looking at conjunctiva.
Thank you, Doctor. Thank you.
So we'll have Dr. Prithvi now, who's going to share about this innovation on slit scope.
Good afternoon, everybody. I'll be talking about slit scope. As we know, when we go to a community outreach center like a camp or something, we always use a torchlight to examine the patients there. We don't really have a slit lamp over there, and it becomes very difficult for us to actually see a lot of clinical findings without a slit. Because we always have a diffuse light. Even cataract bleeding becomes a little bit of a problem. So what if we could have a replica of a slit lamp? So that is why we started seeing it as a problem. And hence we started seeing what are the solutions. So we needed magnification, we needed slit illumination, and we needed an imaging device. So these were the three things which we broke it to, and then we had a magnification and imaging device we already had. So we use a ASP. So this is actually a chart paper in which a 15 diopter IOL has been sandwiched to, and it is connected to the smartphone. So once that is done, we are able to actually magnify the images of the entire segment. We could see each and every finding magnified in the smartphone. So the next thing was the slit illumination. That's where we came with a slit scope. These are my co-authors. And so we opened up a slit lamp and saw what the basic principle is. That's using a light bulb, a slit mechanic, and then a lens, a convex lens. Over here we used a IOL. So intraocular lens was a convex lens. So this was the prototype which we built, in which you can see we made a slit with the chart paper. We put it on a moonlight torch, and then the IOL. And now with the 23 diopter IOL, we could actually make a very thick slit. And this was the first image taken with my own eyes. You can see how the slit was made, and it is a little thicker. So this was the first attempt and the prototype which we came up with. And this was taken completely without a slit lamp. So then we thought, why not explore this whole thing with the 3D printing technology that we have right now. So then we started designing and making different adapters in different shape and with different slit millimeters, and we could make it a single adapter with just 350 rupees. And this we need to actually get on top of the torchlight, and then when you on it, you actually get the slit images, light. And with the ASP, we could actually take images like you can see over here. The first one with the image cataract with PXF. The other one is a multifocal IOL. Over here you can see a corneal scar with the pseudophakia. Other one with the blue dot cataract with the sutural cataract. And these are all taken without a slit lamp, just with 350 rupees adapter and another IOL for the smartphone. Over here you can see a brown cataract and mature cataract. So we could actually even start grading the cataract nuclear status also. And so this is a very simple, cost-effective, do-it-yourself. If possible, you can even 3D print it, and could be a future alternate to the slit lamp. Thank you.
Is this a standalone torchlight in addition to your phone, or is it mounted on your phone?
No, it's a standalone. At present, it is a standalone torchlight, and we one hand we used to use the torchlight, and the other one with the ASP. The future 3D printed which we have is actually something which is
integrated.
But
there are devices which are available commercially. I saw one somewhere in Taiwan or something else, which you can clip it onto your phone, which is like a rod.
Yes.
So that provides it. So if you are able to provide that, like create a 3D printed one which clips onto your phone, that may be much easier to use. And definitely it's going to be very, very useful to people here, I think.
We have actually already designed it. We have a provision where we can actually change the IOL so that we can get different type of magnification and field. And we also have different apertures of the slit.
Actually, that may not be necessary, because like all these phones have a zoom capacity. So you're talking about two lenses, one in front of the objective of the phone lens for imaging, like magnifying the anterior segment, and there's another lens which focuses the slit onto the eye, correct?
Yes.
So that lens maybe you may have to alter to look at the distance, but this actually you don't really need another lens in front of the objective of the phone, because you can zoom it up and that gives a beautiful view. Because we have been doing this for some time, but then we didn't create a slit. But if you can create one device which you can clip onto a phone, that will be great.
Yes, sir. Thank you.
Thank you.
That's again an interesting presentation, because creating that slit is the most difficult part. No, many of them have just tried to zoom up the eye with macro lens, and Prithvi came up with the brilliant idea of using the intraocular lenses, which became the ASP, and many of the residents now use that. No, so whenever they drop a lens, they don't just leave it to the floor. Now they try to fix it to their phones. So we have Dr. Shishir here, Shishir Varghese, So he's going to tell us about visualizing the obscure, the chromophore assisted retinal break detection. Yeah. It's a video, okay.
utilizing the obscure, chromophore-assisted retinal break detection. A 62-year-old male presented with decreased vision in the right eye. He underwent pars plana vitrectomy for rhegmatogenous retinal detachment 3 months back. The right eye vision was hand movements and anterior segment examination revealed pseudophakia. There was no view to the fundus. B scan revealed dispersed vitreous cavity hemorrhage and retinal detachment. He was planned for a repeat vitrectomy. Intraoperatively, a retinal break could not be localized and hence subretinal injection of BBG dye was thought of. BBG dye was loaded in the subretinal injector and the injection pressure was lowered. A 41 gauge needle was used to inject the dye in the subretinal space. PFCL was injected to displace the dye to the retinal periphery and the plume of the dye was noticed emanating from the now visible break. We show this again in slow motion. A relaxing retinectomy was done followed by endolaser, fluid air exchange and silicone oil injection. Post-operatively, the retina was attached under silicone oil. In retinal detachments, if no peripheral breaks are visualized, surgeons tend to make a posterior draining retinotomy and drain the subretinal fluid, the necessity of which can be confirmed after subretinal BBG dye injection. In vitrectomized eyes where it can be difficult to identify the SRF egressing via the break, subretinal BBG dye provides a color contrast that enhances break visualization.
I'm sorry, I hope not all of you mind me being a nosy Parker. To introduce myself, I'm Dr. Mahesh Shanmugam. This was a technique described by Dr. Bill Aylward in 2014. So, where you can't identify a break, you inject dye transretinally. So, we have a modification, we inject transclearly so that you avoid even this retinotomy. So, you inject the dye and then put the perfluorocarbon and the dye comes out and you're able to identify the break. One thing is the purpose was defeated in this case by doing a retinectomy. So you identify the break and treat that, that should be adequate. But then that was one thing which was there. But nice video. Thank you.
Thank you. Thank you. So the idea was because the break and all sometimes in redetached eyes is very scarred and you really cannot see the break. So the idea was to inject the dye subretinally and then displace and see the break. It's extremely useful sometimes in patients with albinism also when they come with a retinal detachment and then you really don't know the break because of the color contrast. So the dye helps in detecting that. Thank you.
Anybody else from the retina side can comment on this? Our knowledge in this is limited. Anyway, it's really a very good presentation.
Thank you, sir.
Thank you, yeah.
Think of somebody when they came up with the Trypan Blue idea for even mature cataract. Now, before that, you think how we were doing mature cataracts. We were just guessing and doing Erexis. So I think all these things are incrementally, you can make the procedure better and safer. And one such person who makes a lot of procedures safer, we have the last presenter, Dr. Vivekanandan, who is going to share how he is doing an iridodialysis repair in a novel way.
So good morning, everyone. So I'll be talking about a new surgical technique and a few other innovations to make this technique safer. So the in and out iridodialysis repair. So we all know it is a very challenging process. Involves peritomy, creating flaps, multiple sclerotomies. You have to not damage the lens and a lot of other things in order to have a proper fixation of the iridodialysis. So here is our technique. So this is a traumatic cataract with around 4 clock hours of iridodialysis. First, the iris hook is used to keep the iridodialysis at bay, and then rhexis and phacoemulsification is done. Luckily, in this particular patient, the bag was strong, no zonular injury. So the IOL was placed in the bag, and then the hooks were released, following which the viscoelastic HPMC is washed, and then a high molecular weight viscoelastic is used to flatten the iris, because HPMC, the iris tissue tends to roll. After that, the iridodialysis extent is noted and the places of marking is indented. The conjunctiva is moved radially and a sclerotomy is done using a specially designed needle, a spatulated needle which is 150 microns, into the anterior chamber at the level of the iris plane. Once the needle is in the anterior chamber, using microforceps, the peripheral iris, which has to be anchored, is pierced with the same needle, and the needle is exteriorized through the clear corneal incision. A U-turn is made with the same needle and it is interiorized into the anterior chamber, and the second anchor point at the peripheral iris is held similar fashion with the microforceps, and at the level of iris plane it is punctured while simultaneously the conjunctiva is moved radially. So now you have a loop of suture inside the anterior chamber. So once the loop is complete, the suture is pulled till appropriate approximation is achieved. The suture is trimmed, and using a portable cautery, about 1.5 millimeter of suture is flanged. Once the first flange is complete, the second suture is pulled so as to bury the first flange below the Tenon's membrane. Once you are sure it is below the Tenon's, the second suture is also trimmed to about 1.5 millimeters and a flange is created. The conjunctiva is pulled, tucked. Now you can see the two flanges anterior, whereas the conjunctival opening is much posterior, so as to prevent direct entry. So this is the image why the conjunctival movement of radial movement is to have both of them at different planes. We don't want a wound exposure, we don't want an infection. So this is just an animation. The conjunctiva is pulled and the sclerotomy is made in a similar way. So at the end of surgery, your sclerotomy is at a different plane and the conjunctiva is a different plane. So this is one small innovation we did to have safe post-operative results. And then the instruments required is a portable cautery, and this is a spatulated needle designed by us, which is 16 millimeters attached to 70 and 60 Prolin sutures we have. We do the 70 for iridodialysis repair. Why we had to come up with this invention is the 26 gauge needle and the 30 gauge needle, the diameter is very different. It's large, and it's a gauge needle. It is hollow inside, so you have a circular opening in the sclerotomy. So we came up with a spatulated needle which is 150 microns, and the maximum dimension that it will give after the puncture is 250 into 120 microns, considerably reducing the amount of suture to be heated and flanged. So when you heat to a 3.5 millimeter of suture, the flange is big. You can see a tear film elevation in certain cases, whereas with 1.5 millimeter, it is just a small dot underneath the T-nuts. And we also did a few lab tests to determine the pressure, how much is required to make the puncture. So with the spatulated needle, the force required to do a sclerotomy is the gram force is much lesser compared to the 26, the conventional 26 and 30 gauge, so that we have a less traction or less injury to the eye. The other best part is when you make a sclerotomy with the 26 gauge, you can see a literal hole in the sclera. Whereas with this spatulated needle, you make a puncture and you don't see any hole. So the amount of suture that has to plug the sclerotomy is somewhere between 1 to 1.5 millimeters. So with the 6-0 Prolin, it is less than 1 millimeter, whereas with the 7-0 Prolin, it's up to 1.5 millimeters. So it is just a blue dot post-operatively. So these are a few results of the post-operative day 1 pictures of iridodialysis repair. So we've done so far 8 cases we've done in the last 2.5 years. Not only this same suture and needle, we are using it for making the flanged SFIOL and the CTS. In the last 2.5 years, currently we've done over 300 flanged SFIOLs, and CTS placement becomes very, very easier, and iridodialysis around 9 now. So these are images of the flanged SFIOL. So the advantages of this technique is that there is no peritomy, the learning curve is much shorter, less time consuming, no scleral flaps or pockets, less chances of suture tract infection because we move the conjunctiva radially before making the sclerotomy. And at last, good cosmesis in immediate post-op. There is no congestion. All you see is a small blue dot. And we have post-ops up to 2.5 years, and the results are phenomenal. Thank you very much.
Sutures, how long do the integrity of the sutures?
Sir, this is a Prolin suture, sir. So Prolin suture, ideally with the knot, it lasts up to 10 to 15 years because the suture gets crushed. Whereas this is flanged, the suture is not bent, nothing. It is melted in its own plane. And we've done some lab tests, which I have not showed here. The tensile strength is it's almost triple the time as a knot. The knot strength is 1/3 as of a flange. So, and the other part is, sir, we are not stretching the suture or stretching the IOL in any case. We are just placing it loosely so it stays there forever.
Thank you.
Thank
you. It looks like we are perfectly on time. We have another 5 minutes for you to freeze the results. If you don't mind, you have to tally it for us. இல்லை யாராவது வாலண்டியர் இருக்காங்களா கூட்டுறதுக்கு கழிக்கிறதுக்கு என்ன மீனா? Do you have volunteers here? Okay, thank you. இதை ஒன்று எடுத்து கூட்டுங்க. We're going to announce the result now, but the prizes will be delivered in the valedictory function. So they want you to be till Sunday afternoon if you want the prizes.
You want to announce it now itself?
Yes, the results are going to be announced now.
It's very difficult to, because all the presentations are really good, are very innovative and very simple, and they are really thought, all the youngsters, they have done wonderful work. And we really love them, and I don't know whether we'll be doing justice to
we'll see. It's difficult to do because
it's very difficult.
Because all were very interesting innovations. Again, at the end of the day, it's the applicability and how you feel that it's going to bring some change in your practice or others' practice.
True.
So, மூணையோட average வேணும்பா. If you have any other questions to these people, you can always throw now. We have 3-4 minutes.
Very, very innovative session. It's really innovative not only in the science, but also in literature. You see the words what they have used, it is very rare combinations of words taking us back in history or what is in the present, like the scrapboard or Odyssey, all these words.
Yeah, generative AI la irukanga sir. You are with somebody who is using generative AI now. Yes,
so,
Mahesh. Yeah.
Very nice. Question to Dr. Parikumar. Is it based on conjunctival images right now, or is it based on a biopsy?
And the mic enga irukku sir?
It's biopsy, based on biopsy.
Based on biopsy. And subsequently you're thinking of working it on a...
Yeah.
Okay, so you're expecting that you'll do a biopsy, but of course it's a patented stuff. So you're expecting you'll do a biopsy and then see if the patient will have a diabetic retinopathy or diabetes or hypertension or something.
We're working on predicting this is earlier than retinopathy.
Okay. Oh, earlier than retinopathy. But then right now the AI based on fundus images is able to predict it, sir. So how is this a little better than AI? For fundus
AI
images,
in the sense
because that's non-invasive.
Non-invasive. It detects only after the damage happens, after the blood vessel breaks. Here we are detecting at the cellular level where the endothelial cells are infiltrated, the endothelial cells begin to flatten. At that stage itself we can pick up. Earliest stage we can pick up any vascular inflammation.
Yeah, I'm not sure whether the answer is perfect, because machine learning now seems to be picking up even before whatever you're saying as damage. Damage we are seeing as hemorrhage and exudates. Yes. But it looks like the machine is learning what you are seeing in the lab also. So that is what is interesting in We don't know how the machine learns.
That is one of Dr. Kim's favorite statements is like it looks at the fundus and that Google is able to say if it's a male or a female by looking at the fundus image.
Yes.
That's how it is.
Now from the conjunctival vessel,
Yeah.
the work is going to conjunctival blood
It's
vessel.
possible.
Must thank Dr. Magesh. He should have sat here.
No,
He
but
has
he'll
done a
agree.
wonderful
He'll
job.
agree with your result at the end of the day. No,
Very nice session. We learnt a lot also. And
No, the
applications
most
also.
interesting part, if you see, they are all in their residency or they just finished residency.
Youngsters.
But they want to solve their problem. And if they think that they're going to solve their problem, I'm sure they're going to solve several other people's problem here. And that's nice to see, these youngsters who are trying to make this world better. So how many of you use ChatGPT here? Can you raise your hand? I see a very few hands. Now we will strongly recommend you to look into how it's being used. Best is ask your, 8th standard or 9th standard kid if you have back at home or a grandkid. They are the right people to teach you how to use it. Like even yesterday I was just trying to put a chapter on neovascular glaucoma and I said give me 10 MCQs. 10 seconds. No, for a class you are ready. And then you say give me 10 tough MCQs. It's there.
Easiest actually right now is to condense your abstract to the number of words
Exactly.
For instance, ASRS or AOSAX. So like ask ChatGPT to condense your abstract to 500 words, it does that. So, and also it can write the articles without the data. That's a second step. So plagiarism is something which is people are looking at. That's also another thing which...
Interestingly, I gave an article recently, we published something on shared medical appointments and said, give me a press release. It beautifully gave a press release for 100 words, 200 words, 300 words.
Yeah, you can amuse yourself by asking ChatGPT to write a poem on yourself. Yes. It does search about yourself and then writes a poem also.
So start using it, so that you don't use a little bit of your brain which you had before also. முன்னாடியாவது ஒரு 150 வேர்டை எப்படி 100 வேர்டை ஆக்கலாம், இந்த அண்டு எடுக்கலாமா, அந்த தட் எடுக்கலாமான்னு யோசிச்சுட்டு இருந்தோம். இப்போ அதுக்கு வேலை எல்லாம் போயிடுச்சு. So we have a minute more for 12:45. இது ப்ளே பண்ணுமா? போடுங்க. மினிட் இருக்குல்ல? இல்லை இது பாருங்க.
So cute they are. ஜோடி பொருத்தும் பிரமாதம். என் கண்ணே பட்டுடும் போல இருக்கு. ஆண்டி இது என் அப்பா. சாரி, என் ஐசைட் அப்படி இருக்கு. நான் போயிட்டு வரேன். எல்லா ஆல்பமும் ஒரே மாதிரி தானே இருக்கு.
ஃபாரின் படம் பார்க்கலாமா?
Why not? என்னால் சப்டைட்டில்ஸ் அப்படியே படிக்க முடியுது.
Oh, like that.
எதை பார்க்கணும் எதை பார்க்க கூடாதுங்கிறது உங்க சாய்ஸ். டாக்டர் அகர்வால்ஸ் வழங்குகிறது வலி இல்லாத தையல் இல்லாத சர்ஜரி மற்றும் அதே நாள் டிஸ்சார்ஜ். டாக்டர் அகர்வால்ஸ் ஐ ஹாஸ்பிட்டலுக்கு வாங்க, வித்தியாசத்தை நீங்களே பாருங்க.
How many of you all would like to go back and start innovating something after the stimulation? How many of you all like to go and start doing something new? I hope it is an inspiration. That is why you are all sitting here. Just to clap for them who have done it and take some message home and try to innovate something else and come for the next conference prepared to present something new.
How many of you would like to use a tall lamp? Who are having spinal issues, cervical issues? Let's say that. So think of when you're setting up a new clinic or a new hospital, even think of something which is like an hydraulic, which goes up and down. So whenever you want, it will go up, it will raise. இப்போ நம்ம வண்டி சர்வீஸுக்கு போகிற மாதிரி சார், காரை தூக்குற மாதிரி, that stage will raise and then it will go. Then you can sit normally. So if you even set up like that in that particular space where you want that to be raised, it's going to become like a long-term investment for you in your clinic.
how the mindset, when you want to try something new and then attempt it regularly. I find it difficult for my surgeons to switch over from the stool, revolving stool, to a chair, backrest. Only when they get into the problem, they want to change it. Even for a retinal surgeon, they are happy doing with this.
That's the problem, sir. They
Everywhere.
சொல்கிறோம் இல்லையா, இந்த 40 வயசில் தான் வெள்ளை எழுத்தை பற்றி தெரியுங்கிற மாதிரி சில நேரங்கள் வந்தால் தான் வலி வந்தால் தான் அதை பற்றி தெரியுது அவங்களுக்கு.
ஏன்னா அது ஒரு செட்டில் பழகிட்டாங்கன்னா அதுக்கப்புறம் மாறுறதுக்கு ரொம்ப கஷ்டமாக இருக்குது. That's a major issue when we want to attempt, experience that, experimented on that, and this is a major challenge for all of us.
It's very sad that now they don't use microscope foot pedal, they're using the table foot pedal to adjust the table. Just to focus, they are using table foot pedal.
Yes.
No, up and down. That's really going to put a lot of things into the back which don't realize when you're young.
Yeah.
When you're 27, 28, you don't realize. When you become 38, 48, and then you realize, oh my God, I shouldn't have done this. One of the presenters is just 30 now, who had to innovate the tall lamp. Now, because you get now at much younger age all these problems. Is it done? Is the next team here for the next session? Can you raise your hand? நீங்க தானே அது? இந்த முடிஞ்சிருச்சு.
JK, you'd like to say a comment on this session? Few words. He is an innovator. He has a lot of innovations he has done. JK, any few words?
12:50. You'll give exactly at 12:50. Is it ready? Okay. அவங்ககிட்ட கொடுத்துருங்க.
I request Dr. Ramakrishnan sir, President TNOA, to come and announce the result.
சார் வாங்க. பட் ஏதாவது உங்கள் பையன் பேரை சொல்கிற மாதிரி வச்சிட போகிறாங்க சார். ஏதாவது ட்ரிக் இருக்க போகுது அதில். எதுக்கும் கேர்ஃபுல்லாக வாங்க. டிஸ்க்ளைமரில் சொல்லிடுங்க, ஸ்கோருக்கும் உங்களுக்கு சம்மந்தம் இல்லை. It's done.
Thank you, Angelesh, for conducting the session very nicely and interestingly. And also I have to thank all the judges. And before that, I have to congratulate all the presenters. At this young age, they have done remarkable work, either the pupillary reflex or progressive lens, this one, and also the for subtenance injection, the magnification, illumination, and also the slit lamp, and some surgical technique, retina, and it's wonderful. So I once again congratulate all the presenters. Definitely ophthalmology is in the safe hands in future. I'm very, very happy. Yeah. Now the results. The third prize goes to Dr. Vigneshwar for his tall slit lamp. And the second prize goes to Dr. Prabhu Krishna for his this one. And the first prize goes to Dr. V.R. Vivekanandan. Yeah, all the prize winners, please come over. Yeah. Yeah. Thank you very much. Yeah.
போயிட்டு இருக்கு, நம்ம ஸ்டார்ட் பண்ணலாம். நீ லோட் பண்ணாச்சு. யா திஸ் கம் தம்பி சீக்கிரம்மா, பசிக்குது. நீ நீ மெதுவாக வந்த போது எல்லாம் வெளியே போயிடும், சாப்பிட்டு போயிடும். நீ டக்குன்னு அப்படியே வந்துட்டு இருந்தால் நம்ம உட்கார முன்னாடி வச்சிடலாம் இது.